So, ladies and gentlemen, a terrific panel. Please give them all a very warm welcome. Now, Sally, you were the forum chair, the sort of lead author of the report that's been written, thanks to WISH, tackling antimicrobial resistance, how to keep antibiotics working for the next century. You've done an awful lot of work with your team on this report, so I know it's a difficult thing to do, but if you can sort of summarize, give us what you think are the most important bullet points to come out of the report.
Thank you. It's not just me, the co-chair was the Lord Darcy. So let's remember the size of the problem. 39 million people will die by 2050. It's going up, particularly in the vulnerable and over 70s, but if you've got prevention in place, it's falling in the under 5-year-olds. But this is serious, and we've had no new classes of antibiotics since the late 80s. So put that context, and I can expand it as you wish, but at least 1.2 million dying directly of AMR every year, and up to 5 million or more with associated AMR.
I'm going to stop you briefly just to tell me how it works, how you can define so specifically how many people have died directly as a result of AMR. You know, what are the circumstances we're talking about?
The Global Burden of Disease study, where they've gone through, I think it's 233 million individual patient records, and they're epidemiologists that then model it. But what they look for is, did the person die of an infection where there was resistance? Did the person die and have an infection that may or may not have contributed? By definition, it did, where there was resistance. So you get the direct deaths and the associated.
Right.
And that 5 million figure is going up, because remember that 1 in 4 cancer patients get serious infections. We did a poll a few years ago of cancer docs in Britain, and it was in their top 3 worries for cancer patients. So this matters. So to put the report in context, in 2016, we had the first high-level meeting in New York at the UN General Assembly, at which most countries said, yes, it does matter. But they didn't really know the full concept of the One Health, the impact on humans, the need for stewardship, the issues in the food chain, let alone the impact on the environment from effluent, whether human, animal, or factory. So we can go into all of that. Come back this year in September, and the environment has changed politically in that everyone knows they've got to take action. And that's where this report picks up. We need to take action. And so the first recommendation is about supporting the political declaration from that high-level meeting that was negotiated between all the countries, and it was difficult. It's very strong on some things. I particularly welcome Britain has fought hard for the setting up and development of an independent science panel, a bit like the IPCC, to review the evidence, to advise countries. It's not going to set targets and monitor people, but more to bring it all together and give some advice. Wouldn't it be nice to know that depending on the prevalence of infections in your country, what level of antibiotics would be reasonable, and then to look at it, sustainable, perhaps the word I'm seeking, and then to look at it and say, but do we actually have access to those antibiotics? So a big focus on the high-level meeting is recommendation 1, independent science panel. Then it goes on, the report with the second recommendation, which is essentially about the national action plans. We all agreed in 2016 to write national action plans that would cover the whole spectrum of One Health. Unfortunately, though, a number have been written, only 11% are funded. So we really need to galvanize that.
And when you say we all agreed,
all countries.
The whole world?
Yes, signed up.
Yeah.
At the UN and through our governance of the WHO, Food and Agriculture Organization, the World Organization for Animal Health, and later the UN Environment Programme. But it's not happened. So how can we help countries that are short on money take their national action plan, prioritize, and get on with it? And a lot of this is about prevention, access, and then stewardship, which we've mentioned already. The third recommendation is essentially, let's start at the beginning and prevent infections, and we focus particularly on what's known as WASH, water and sanitation, and hygiene, which is infection prevention and control. The importance in everyday life of all of this: over 50% of health facilities do not have clean running water. That's wrong. It's not fair. It's not right. So we need to sort that. But alongside that, the routine vaccination programs in childhood and old age. Particularly important in old age because we now have the latest data from the Global Burden of Disease that shows AMR going up in the over 70s. So we need to think about that. The fifth recommendation is addressing innovation. We've had no new antibiotics, clinical class of antibiotics, come into routine clinical practice that was discovered before the late 80s. I mean, you know, no wonder we're having people dying. We need good diagnostics, but we need new drugs to cover these resistances. The only way I can see...
Isn't that just delaying the problem? Because then you'll just get a new round of resistances growing up to the new drugs. Is that really the way to go? To tell the scientists to come up with lots and lots of new antibiotics?
I think when you're on your deathbed with AMR, you'll wish they had done it. But this is not a war you can win. This is something we're going to have to do repeatedly.
Yeah.
And people have reckoned that we need 3 new drugs every decade.
But I mean, without wishing to delve too deep into the science and without wishing to reveal my utter ignorance, are you saying there's almost an infinite possibility for endless new sort of antibiotic treatments? The scientists just need to go out there and focus on this as a priority.
If you'd asked me 10 years ago, I'd have said the science was very difficult and we couldn't do it. But now, with lots of new science, bringing in AI, looking at screening things, yes, I think that's part of our future. And we've got to do it because it takes a minimum of 10 and generally about 20 years to get from a drug target to a drug that we can use. If we don't get on with it, many of us are going to die unnecessarily of drug-resistant infections. And the only way we've found to solve that market failure, and Britain has pioneered it, Italy's coming in now, are with what are called pull incentives, which is a special mechanism of paying a subscription as if it's a fire extinguisher. I could expand, but I guess you don't want me to.
Well, I don't at the moment because I want to introduce everybody and get everybody talking.
The final recommendation is picking up on where Aradazi was.
Yeah.
Let's really give a big push and make the centenary of the finding of penicillin a good one, in the sense that we begin to look at the social sciences, really do the innovation, and take this forward effectively. That gives us some 3.5 years to work on.
Yeah, it does.
We could do a lot.
It's not far, not long till 2028, but I take the point. Sally, thanks ever so much, because that's a brilliant beginning and an overview and tells us much of the sort of bullet points in the report and what the report is looking to address this problem. So now let's go to a particular region. Let's go to the Eastern Mediterranean. Dr. Hanan, you are the regional director of the WHO, so I want to know what is happening in terms of this AMR problem in your region and how the WHO is trying to address it.
Thank you very much. It's a true pleasure to be talking about a topic so close to my heart as a pediatric infectious disease, but also as the first Assistant Director General on AMR for the past 5 years before becoming the regional director. So I worked very closely with Sally and with a lot of the AMR network globally and of course regionally and nationally. The previous session that you were moderating also pulls very much into my region. As you understand, 750 million people in the Eastern Mediterranean of WHO, the largest number of displaced, the largest need of humanitarian assistance, and the largest number of countries under sanctions.
Yeah.
All of these create a huge challenge in how we're going to address AMR. And I've already, since February taking office, I've already visited 9 of the emergency countries. Just got back from Djibouti and Somalia, but I also entered Gaza in July, and I was in Afghanistan, Pakistan, and Sudan twice, and so on. What I saw coming from the academic world and a healthcare provider for 20 years, moving into the UN system and doing what I'm doing today, I realized that there's much work that needs to be done on antimicrobial resistance. Sally knows my opinion very much about this, especially after being in the region. And as you correctly said, you're not naive at all. In fact, your question was spot on. We do need to continue to produce new antibiotics, but we need as much as a robust intervention to improve public health.
Sure.
Now that goes into stopping wars, first of all. If we can do that, that would be brilliant. Because what I saw in Gaza with the running sewage, piled garbage, what I saw in Djibouti with the lack of sanitation infrastructure, coastlines that are a bit brown from sewage, the smell of the fermentation. We talk about dignity, so it moves me sometimes emotionally away from AMR into dignity and humanity. But at the end of the day, the issue of antimicrobial resistance, which I don't like to equate it with HIV to be malaria, I equate it with the climate change. It's a phenomenon that is way broader than any one disease. The resistance that you were reading in the reports, you're not talking about one pathogen. You're talking about a bug that is continuously improving its DNA or its genetic armamentarium to resist whatever we produce. Sally said 10 years to produce an antibiotic, which is true. But how many years do you need to create resistance to an antibiotic? 2. And that's 2 if you're doing a good job. It could be even faster depending on the antibiotic. The innovation, I won't talk about the innovation now because that was not your question, but maybe later. So in my region, where the WHO, in my previous job, we've worked really hard on national action plans, creating more support for countries to understand the burden of the disease, specifically not through modeling, but the reality, and it's very costly, so we're very thankful for the IHME, the Graham report. However, heads of health sector need to know the reality, because for them to do their interventions, they need funding. They need to be able to support the One Health agenda. So what we're trying to do is to bring more technical, financial, collaborative support to the member states of the Eastern Mediterranean region. I'm trying to highlight it as the pathfinder for the One Health agenda, which it could be, making sure that there's health in all policies, which is a new language in the health sector to make sure that the other sectors do their job. But what is really needed is for us to look into very, very basic, I don't want to say 7th century, 8th century, 10th century public health issues that are daunting in the Eastern Mediterranean region. Close to 95% of patients evacuated from Gaza when identifying a pathogen are already resistant. Now, these patients have left Gaza into other health systems, and again, we have seen the same thing when during the Iraq War, where Iraqi Bacter, Acinetobacter, went to the Western community, very resisting pathogens. So as the wars, public health, economy are problems.
I think that's a really important message, that we can, and we will, talk a lot about the science, about the latest technologies and developments, but fundamentally there's an intimate link between the AMR crisis and conflict, instability, failing states, poor governance. All of these are underpinnings of the problem, and we need to get our heads around that.
100%.
Yeah,
yes.
good. All right, well, thank you so much for that. Now, one perspective that really matters in all of this is going to come out. Oh, by the way, before I get to you, Noor, I should have said already, we are going to chat and hopefully have a really thought-provoking discussion, but one of the important elements to all of this is that you guys, and I hope you're sitting there with your smartphones, you can be part of this, because we absolutely want your questions. In the previous session, I managed to get a few of the questions in. The way to ask a question is to go onto the Wish app, which I hope you've all downloaded. If you go to this particular session, click through to this particular session, you'll find there a page where you can actually put down a question. And I've got my phone here. I will, I assure you, be monitoring it, and when questions come in, I will put them to the panel once we've heard from all of them. So it is interactive, and genuinely, I say this with no false modesty, your questions are going to be better than mine, so do ask them and I will get them. Now, sorry, Noor, back to you. I was about to say one perspective that really matters is those who are directly affected by AMR and whose illness, you know, is absolutely connected to this rise in AMR. You, I think I'm right in saying, are not just a specialist in infectious diseases yourself, but you've had family impact from this particular problem. Am I right in saying that your mother was subject to an AMR-related illness?
Yeah. Yes.
Is she still with us? How is your mother?
Yeah. She's
So,
alive and well, yes.
good.
She says hello.
I'll tell you what, begin by talking about what happened to your mother, and then tell us how you think that those people, you know, patients who are living through this and their families can be a part of this discussion.
Yeah. Thank you. So you're right. I start off by saying that I am an infectious disease pharmacist in background, and my mother's journey helped me understand AMR a lot better. So just briefly, in 2018, I was at a conference, an infectious disease conference in the US, and it was about the time that we started learning about combining 2 antibiotics to treat a very resistant infection, type of infection. And that same day, I got a call from my mom saying she had to have back surgery because she was at the gym, she hurt her back. She had.
Where is your mum at this point?
In Beirut.
In Beirut.
Well, right now she's not in Beirut for obvious reasons.
But then she was, yeah.
Yes. And so she had to have emergency back surgery while I was away, but my mom is relatively medically literate, so she was okay with it, but she was also very vocal about making sure that people wash their hands before touching her, before coming into the room, about making sure she takes antibiotics before surgery, and she asked about the name, and she sends me photos. And so after a couple of months of severe pain and a lot of physiotherapy, she started complaining of new back pain. And it took us a few days to recognize that it's actually not back pain, it's actually a urinary tract infection. And it was unfortunate because we all kind of assume things about the way patients describe their pain. And elderly women tend to avoid. My mother, I'll talk about my mother, she avoids complaining because she's so worried about being perceived as a complainer. So it took us a couple of days. By the time that we identified it's a urinary tract infection, it was the bacteria was in the blood. It was through the kidneys in the blood. She had sepsis, and she was really critically ill. So we gave her antibiotics, by the way, paying all of this out of pocket in Lebanon, and also found a way to give her antibiotics at home, because that's also a big deal. How long will you keep the patient in the hospital till they're discharged? And then the last part of this, well, the second to last, is that she started getting recurrent infections. And she started asking me all sorts of questions like, why don't we have better antibiotics for urinary tract infections? I mean, half of you are women, why don't we just have better antibiotics? She also asked me, why is it so acceptable that we have hospital-acquired infections? I mean, because I told her, yeah, you know what, Mom, it happens. And then she said, well, why does it happen? And why are we okay with it? And then, of course, in Lebanon during the economic crisis, it was really hard to get the antibiotics that she needed. And I'm grateful to be working, at the time I was working in Saudi Arabia, and I was able to, through a doctor in Saudi Arabia that had a call with my mom, get her prescription to get the antibiotics. And I don't know if this is specifically legal, but I had to take the antibiotics from Saudi with a prescription to Lebanon, to my mom. And because every time she would have a recurrence, she would need 2-3 days to be able to get the antibiotics. So the access part is super big. And this is me with financial capabilities, able to cover her needs, knowledge enough. People ask me, what would have happened if you weren't an infectious disease pharmacist? The last part to this, which is really relevant to today's talk, is the conflict that's ongoing. And how do people experience the same AMR concerns that everybody else experiences, but within conflict? So my mom had to pack her bags, put all her personal belongings in 2 23 kg bags, including personal belongings and the antibiotics that she thinks she needs. She now lives with me, but she doesn't have insurance where we live. So if, God forbid, she were to have another infection, what would happen then? And this is the best case scenario where she can live in a safe environment. So what would people experience in a school where 20, 30 families live together and there's one bathroom? So I think the patient voice at this point is really, really important, and I really hope that this journey can be described, whether it's in Lebanon or in the US, in a rural community, or anywhere in the UK,
where different stories can give you insight on the gaps that can be targeted to fix the patient journey so that you don't have to deal with these simple to manage problems very often. So we talk about R&D or research and new antibiotics, which is absolutely necessary, but there are a lot of things in the patient journey that we can manage before then.
It's so important to hear real stories of real people, and thank you so much for that. How is your mum today?
She's okay. She's good. She's always afraid of what the next infection will be, and this fear, this mental burden of a pan-resistant infection, which she understands is a big fear for her, but she's physically fine at the point.
Yeah, good. All right. Well, thank you so much for that. And actually, what you just said about the context, understanding the context of this debate, and what happens when societies are not functioning as one would wish they would, it brings us very neatly to Christos. Dr. Christos, I was lucky enough to hear your talk with Yalda earlier, and you spoke so powerfully about MSF and what it's up against in conflict zones. And when we think of conflict zones, of course, we think about the bombs that are being dropped, the devastating injuries and death caused by the immediate impacts of war on healthcare facilities, on healthcare workers, and all of that. But of course, the sort of waves that go out from a conflict go much further than the immediate bomb blast or the specific incident. And it seems to me this discussion is part of the waves that hit a community and a society long after the bomb blast. So explain to me, in the work MSF does, why AMR is such a pressing issue in the conflict zones you work in throughout the world, not just Mideast, but Ukraine, Russia, Sudan, Yemen, wherever.
Because indeed, when we talk about conflicts, we should bring in our minds also conflicts that may have happened 5 and 10 years ago, and wars, or protracted conflict situations, like the one that I have in my mind now in South Sudan. And in all these places, our numbers say that we have an AMR-resistant infections, bone infections, almost 80% of the bone infections in Iraq in 2022, 60% in Yemen or in Gaza these days. And of course, in South Sudan, we see newborn babies with treatment failures repeatedly. And when I start unpacking what is behind all this, we have to understand that AMR in conflicts is a crisis within a crisis. And we can start, of course, looking at the very basics. James Ali said that very, very nicely. We need access to good quality of care, and there's not the case. We need water and sanitation and hygiene.
Yeah.
Yes, exactly. If we get this, we have run half the mile already by having WASH, IPC, the basic vaccination coverage. Alas. And then you start looking at diagnostics, microbiology. Lord Darcy mentioned before that we have to be more thoughtful when we prescribe drugs, and this is true. But how about all these poor clinicians that they are in the middle of nowhere and they have no access in any microbiology, no diagnostics? They do that blindly, or they do it only by looking at themselves and say, this is what I have, I'll give you. And that's so harmful. We know that. These are the situations today in most of the conflict zones. And I repeat, it's not just the war that is happening right now somewhere. It's all these protracted situations. Democratic Republic of Congo being another place. There we need the basics, WASH, vaccinations, IPC. And access to diagnostics, I think it is not that difficult. And we have started some innovative ideas there. And I'm sure that others, and science is what we need to do, is not only to help us discover and develop new antibiotics, but see also how we can make the most out of the ones that we have to treat them responsibly.
Do you think there's a danger of getting the prioritization wrong? That it's tempting because we're all so excited by technological and scientific advance that we perhaps put too much focus on the laboratory and on the science to find whizzy new antibiotics rather than focusing on the core issues that you are so focused on?
I think so. And you framed that very well. It reminds me also some discussions I have with my son. He's only 10 years old, and he thinks that everything can be fixed by coding. We can make the code. He's there. Let's do something, Dad, to improve. And I keep reminding to him and to myself and to everybody that first things first, the basics. And the basics is these very basic things that we are neglecting.
Yeah. All right. So, Karen, I want to turn to you. We've just heard Christos talking about societies under enormous pressure where, basic things from clean water to, access to the most basic antibiotics are lacking. You come from Sweden, where I'm sure none of that is true. So you're in a society, a well-governed country where I'm imagining, but correct me if I'm wrong, that AMR, such as it is being addressed in a very proactive way. But also, I'm wondering whether Sweden is doing, and you are doing your best to use your resources and your knowledge to reach out beyond Sweden to the places where AMR is such a pressing problem.
Thank you very much, and thank you very much for having me in this panel. And really going to a contrast to the far north, Sweden is a country where there has been no armed conflicts for more than a century. So we really start out from a different angle. And I would like to start out from an angle addressing the work of AMR in Sweden. It's really based on a broad public health approach that we have been lucky to establish, thinking that healthy individuals aren't in the need of antibiotics. We won't push the usage if we have a healthy population, that you have really pointed out so clearly, several of you. So in Sweden, it is a strong base to have a national immunization program, to have a child health welfare program, and to have a high priority to participation in these programs, as well as the national public health screening programs to identify disease, chronic disease, at an early stage, in order not having to end up in infections, end up in surgery that will need antibiotics. But to go further in the particular AMR issues, I would like to mention 3 crucial perspectives that has laid the ground for the systematic AMR work in Sweden. And to start up, the first one is a strong ownership in the profession, and that goes both for human medicine and veterinary medicine. In Sweden, infectious diseases was a specialist, its own discipline already in the 70s, and there has been really strong focus on driving research and driving clinical practice in infectious disease. The second one is to have it high up on the political agenda, and that has also been going way back, independent on the color of the government. It has been really high up on the political agenda. And to make sure that we have strong policy, we have strong regulation that gives both pull and push incentives. And third, also to create awareness in the general public. And these 3 perspectives, the strong ownership in the profession, high up on the political agenda, and then awareness in the general public, has been encapsulated in what has been coined the Strama work. And the Strama work is a multidisciplinary approach where it really addresses the aspects of the profession to have good guidance for the general practitioners that prescribe 90% of the antibiotics in Sweden, to make the right diagnostic and to really prescribe the right antibiotics, and then for the policy, and then to reach out to the general public. And the lessons learned from the work that has gone way back is really that if you want to go fast, you can go alone, but if you want to go far, you need to go together. And what we have learned is, both from a national perspective, that we need to have a multidisciplinary approach, and also that we cannot work alone in the far north, in the Swedish setting, and the Nordics and European setting. We really need to reach out and to advocate the work with AMR on a global perspective. So we have pushed really hard together with Dame Sally and other stakeholders, the UN agenda, the high-level meeting, and to have this, the new conclusions and the new recommendations. So to work throughout our experience and to reach out for the global work has really been high also for Sweden. In ODA, as was mentioned, for the British work, but also in leadership to show that it can work. Although the world is experiencing really high levels of antibiotic resistance, by having this approach continuously, we have been able to withstand, even though we've had a lot of immigration and also Ukraine nearby and having patients coming from conflict war zones. By this approach, we have been able to keep the levels down. That is really reassuring that it can work.
A lot of our opening conversation was about, countries where governance is difficult, where conflict zones are affecting the ability of healthcare systems to work effectively at all. But as we're on your Swedish experience, I just want to stick with the developed world for just a second. Is there data which shows that those countries within the rich world that are much more careful about their use of antibiotics, both for humans and indeed for animals too, have a much reduced AMR problem compared with those rich world countries which appear not to have learned those lessons or to be following that practice?
In a word, yes, there's a direct correlation between the regulations and their use, because, for instance, take all of Europe, the same regulations throughout the EU, but the regulations and the guidelines and everything. I mean, Sweden is a leader. Let me be clear, they're wonderful. The further north you go, the more carefully they keep to their regulations, their guidelines, and the public join in. The further south you go, the easier it is to access antibiotics.
I didn't want to peddle.
The higher levels.
I didn't want to peddle stereotypes, Sally, but my impression just from traveling as a tourist and somebody who loves going to southern Europe and to France is that even compared with the UK, it's relatively easy to get antibiotics, and the public sort of expects to be treated with antibiotics if they show signs of pretty much any illness at all. I mean, I know that's a terrible cliche and probably not true, but it's an impression. And I just wonder whether the data suggests that has caused
the
statistically relevant problems.
Is a direct correlation, and I've even seen a paper linking an index of governance with AMR and showing a correlation there. And this matters. We do want to prevent infections, so of course I'm very supportive, and the British government funds a lot to do with WASH. But, anti-infectives, particularly antibiotics, are infrastructure for the health service. You are not safe giving birth by caesarean section without being able to have antibiotics if needed. Cancer treatment, transplants, diabetes, all sorts of standard modern medicine is not doable without effective antibiotics and anti-infectives. So we've got to do both. And I think you'll find all of us agree we've got to do both.
Okay, so as I predicted, there's some great questions from the audience, and I'm going to start addressing them now. And whoever feels like they want to raise a hand to answer, please do. First one is a pretty basic one, but it's important. In terms of the different approaches to the AMR problem, the questioner says, be specific, what is the role of vaccines and vaccination in preventing AMR, addressing AMR problems?
Thank you. Great question. Of course, as a pediatrician, I think I'm expected to answer that. I think immunizations are one of the best discoveries on earth. It was an immunization that got rid of smallpox, right? So I think as a pediatrician, especially now working in these countries, it's very, it's almost like the last hope in some of the member states in conflict. I mean, we have total destruction in Gaza, but we stopped that war for one good reason, that we wanted to vaccinate for polio. So I think immunizations have a huge role in decreasing the burden of illness in general. As you said, people want, and children and young mothers would want to give their children some kind of treatment if they have the sniffles or if they have a bit of a fever or so immunizations might, but they're not the silver bullet at all for reducing AMR. So I think immunizations are great in reducing the burden of disease. At least you do not have some of the viral infections that turn into what we call a superimposed bacterial infection, because that could happen. So somebody with measles, which is a pure virus, you don't treat it with an antibiotic. But someone who gets measles might be in the hospital and acquire a second infection with bacterial infection. I know that was the question, but I'm dying to respond to your comment to Sally, to the high-income countries, because I think what you say, the data of the interventions in preventing the burden of AMR, not only from one country to another, high-income to another, within one country, 2 different hospitals that have different policies and governance over infection prevention and control, antimicrobial stewardship, you can see that the burden of MDROs, or multi-drug resistant organisms, in the same country can be different. So the evidence is there at different countries and different. So I took 2 in 1. Thank you.
Yeah. No, that's really important. Nora, this one is, I think, let's have your response to this one, because it comes back to patients and patient expectations. The question is, how do you address patient expectations for antibiotics to be prescribed? You know, for example, somebody with flu-like symptoms going to the GP expects to come out with a prescription for antibiotics. You know, do you address it through education? Then the question goes on, if diagnostic validation is required before prescription, does this solve the patient expectation problem or challenge?
Yeah, so I have a couple of points here. First of all, I understand that this is an expectation that prescribers think patients want the antibiotic, but there's pretty good evidence that says that patients don't always ask for the antibiotic. And I remember a specific research that was done in Saudi Arabia. It's a very simple survey that looked at over-the-counter dispensing of antibiotics. This is early in 2012, I think. And it looked at how many patients actually asked for the antibiotic at the pharmacy. And I think it was something like 10 or 20% asked for the antibiotic, and the rest was dispensed by the pharmacist. So the first thing is, I think we need to reevaluate our expectation of the patient's expectation. Right. And then the second point is, for sure you're going to have patients that come in and ask for an antibiotic. And I think, there's some interesting work that's been done. Like, for example, the Japanese antimicrobial guidelines includes in the guideline a part that talks about this specific subject, which trains the prescriber on how to respond to these concerns. There's also good research done in Thailand that looks at dispensing symptomatic relief instead of antibiotics. There's also ways to discuss with patients what they want. And no one wants to harm themselves. What they want to do is get better. So if we do a bit of behavioral change interventions, not specifically just awareness, but behavioral change interventions before the patient gets sick. So in July, August, before the flu season, I think it might there is good evidence that suggests that it will improve this discussion with prescribers. The last thing I'll mention is there's good behavioral, that's why what Dame Sally mentioned earlier about behavioral change and how important research is on this subject, but also doing specific contextual research for each hospital, region, country on what actually works for patients. Is it having a promise in the background that says, I promise not to dispense antibiotics without need for it? Is it just saying, you know, you don't need it, trust me? Is it that simple, or is it more training? You know, do you have to regulate brushing your teeth? No, I think people learn that they need to brush their teeth really early on, and then they brush their teeth. And so I wonder if we do early education in schools about the difference between viruses and bacteria. I think there's good evidence to say that it will change behavior. Yeah.
I listen to that and I think, goodness, Noor, you're definitely an optimist.
I am, actually. And I think, you know, of course AMR is really bad, but it could be worse.
With that, yeah, all right. Well, let's hang on to that thought, because I don't want to be the sort of fount of negativity here. Okay, here's a question, and put a hand up if you'd like to address it. It's a very basic one, but I think it's important, and certainly for a layman like me, I want to understand why it's important. The questioner says, what is your stand? What are your thoughts on broad-spectrum antibiotics as a part of this debate? Who would like to take that on board? Karen?
Yes, to start up that discussion, I think they are needed in some instances, definitely. We have patients coming into acute care and we don't know what they are suffering from. We need diagnostics to very quickly identify what type of infection are we dealing with and how can it be treated. And there we need a broad spectrum, but they shall be limited, and we shall prefer narrow spectrum antibiotics.
Is the danger that broad spectrum antibiotics become the default, just the sort of easy go-to?
Absolutely, and that's why stewardships are so important. But I would just like to add on the immunization aspect. Since we're on an innovation summit, I agree. It's not the one silver bullet, but it is an extremely important part of the solution. By vaccinating children especially, and also vaccinating elderly as you reach mature age, there's a high risk of severe infections, and they are driving an enormous prescription of antibiotics. So I think we are only in the beginning of realizing the potential of the immunization programs, and I believe coming now with the RS virus and several pneumonia virus that we can treat by, hopefully, immunization programs in the future. I think that will be one important part of the solution, but not the one silver bullet.
Yeah, I'd love to come in on the broad spectrum, if you don't mind, and I totally agree with you. Because again, there's a big focus in this meeting, and I really appreciate that on the conflict zones. There's a phenomena called antibiotic dump. So when we have a conflict and the whole world is rushing, or most of the world would rush to support, some of the donations that are going, and maybe you can agree to that or disagree, which is fine, the donations are of one or two specific antibiotics with disregard to stewardship. Stewardship means you start broad spectrum, you do a diagnosis, you narrow it down. That's called de-escalation of antibiotics. And it's very critical in patient care. That's what Noor used to do. She used to go around the units as a stewardess and do that. However, in conflict zones, you don't have that privilege of time.
Yeah, exactly.
Either you don't have an antibiotic, and the worst case scenario of amputating legs because they look like they're fermenting, so you need to get rid of the leg in order not for the patient to die, or you flood the patient with a broad spectrum antibiotic if you have it, and you do not de-escalate because you don't have the privilege. So it becomes very complex in the war zone. So I just wanted to add that perspective to the broad spectrum.
Yeah, so Christos, I'd like you to address that too, because obviously it impacts on the work you do.
That's exactly the problem when you have to respond immediately and donate and ensure that at least the basics are there. But this should come also with the necessary medical guidelines. And I think MSF, I'm quite proud of knowing that many years now we've been working on guidelines that we engage a lot with ministries of health everywhere we are, and we try to explain how we can optimize the use of all these antibiotics, especially the broad spectrum ones. But I think it is much bigger here, and listening to all the interventions, I believe that no matter if it is a conflict zone, it is a limited resources setting, or wherever you are, there are some basic things that we have to have always in our mind. And one of them being also how much we engage with the patients and their communities. That can also help a lot. Not only because patients can become very powerful with their stories, and I was amazed to listen to stories in New York from patients that now they lead that. And we know the role that they played also in the past when we were dealing with HIV and AIDS, the post-test clubs. I mean, they changed the game there. And I'm sure that without them, we cannot do anything today. But it's also how we sensitize the communities. And I understand that they are challenged in accessing even the basics. But together, we can see how we can optimize what we have. Because what we need primary health care everywhere. I mean, it's something that you can only design with the communities. And then you start building on that. And when it comes to innovation, indeed, we also try to be innovative. I would like to share with you 2 examples very briefly. The one is that we have these days mini labs. These 6 little parts that is easy to assemble, and I saw one of them also in northeast Nigeria, in the middle of nowhere. Now, we unpack it within a couple of hours. We can have a mini lab and have the basic access to diagnostics. And then with your smartphone and with the help of the AI, you can read, actually somebody else can read an antibiogram for you and tell you what to do.
So you're saying you have 6 mini labs in the whole world?
No, I mean 6 parts that can just unpack. It's like 6 suitcases.
So how many? I mean, do you have how many mini labs have you got?
We use them in a few of our projects, and we would like others now. We are engaging with ministries of health to start getting inspired by this idea. We don't sell the products, but the idea is there, and we really encourage others to make use of that. And then Antibiogo is this smartphone application. So there are, and I'm sure there are plenty of other things, but we need, again, coalition. We need the leading countries, and I would like to see more of them, Sally's and Lord Darcy's, more of UK's on this, and Sweden. And we need also to make sure that we move together, all together, because some may take some more time to rush behind us. So even the policies that we produce, they need measurable indicators, but indicators that can be well adjusted also to the realities of the poor society.
But it strikes me it's a bit like, I think somebody already mentioned the analogy to climate change. I mean, it's a bit like that in that we all know it's a global problem, and we all know we're interconnected, and we also all know that the rich world has many more resources to deal with the problem than the poorer world. And so the question then is whether the rich world is really prepared to step up to the plate and, devote significant resources, not to its own populations, but to doing work to help populations that are much less able to help themselves in this particular respect. In climate change, huge promises of hundreds of billions of dollars of transfer of resources from, the long-time industrialized polluting world to the poorer world have been made, but those promises haven't been kept. Are the promises going to be kept in this particular field with real commitment to long-term resource transfer from the rich, healthier world to the less advantaged parts of the world where this problem is most pressing?
Of course, it's going to cost a lot less than climate. Yeah. And most of the antibiotics we use every day are generics and very cheap. We do have a problem with diagnostics. The gold standard is not really a very good one. It's blood cultures, and we need a better gold standard. So from Britain, our Fleming Fund has spent 280 million in 25 African countries, developing capacity and capability in laboratories for surveillance, but then that means you can do diagnostics. And we've trained a couple of hundred fellows, and that there's another 90 million flowing. And that has been really good, because what you begin to see is that once you've got that basic training in, actually to keep it running is not that expensive. So for access to antibiotics, the antibiotics don't cost that much, but because the countries have not managed to look at their own burden of disease themselves and work out the demand, they can't do a procurement at a cheap rate. The minute we can help them unlock that demand and work it out, they'll get a much cheaper rate and be able to afford it. So the issues are, how do we help them understand what their problems and priorities are in order that they solve them themselves, and that will cost less. It will need support from the global north, of course it will. I've said that ever since I've been working on this. But Sweden helps, the Netherlands help, we help, many countries help. What we really need is the prioritization by countries about what they see as their big problem to start with.
Let's address our minds then to looking forward to science and technology, and you've already talked a little bit about the scope for developing new ranges of antibiotics and the importance of lab work there. And we've briefly mentioned AI. Here's a question that picks up on that. The questioner says, there's a fine balance between not overprescribing antibiotics and not delaying appropriate antibiotics when needed, especially in critical conditions like sepsis or meningitis. Apart from solely relying on physician diagnosis, what else can be done? Is there a role for artificial intelligence here to help achieve better, quicker, more reliable diagnostics? Who wants to wade into the world of AI?
Maybe I'm not the right person, but
No.
I will bring it at another level, because of course there is a role, and of course they can help. They can help the physician, but not replace the physician. When I think of AI, wherever in a room, I see this as a third partner between the physician and the patient that they can help. And there it comes to what we discussed before about what are the expectations by the patients. Do they seek for this silver bullet always, and what is this? And that's where the physician can remind that what you are expecting from me is to get well, to go back to a level of well-being. And that's more important than prescribing the silver bullet antibiotic or not. So let's sit down together and see how we do that. And AI, of course, can help a lot, and I'm sure that in the coming very, very few years we will see that.
I'm happy also to come in on this. I think, as everybody would agree, the AI is a huge door that's opened up, and I think whether it's going to help in creating smarter algorithms for treatment, so that we cut the chase and try to get to the right treatment quicker, if that's helpful. But I would love to see the dream for AMR, and we talk about it a lot at WHO in developing the essential pathogen list and in developing the pipelines for antimicrobials in the pipeline, so you can find that on the WHO website, to also help the scientific community understand what is coming in and what is their quality of innovation. As Sally said, we have 10 years to develop a new antibiotic, none for many, many decades. But there's no innovation in an antibiotic that is resistant to resistance. So can digest that for a second.
I'm trying to get my head around that. Okay.
So the bottom line, can we develop an antibiotic that we give to people when they're ill, that the bacteria finds no way to resist it being killed by it?
This is a super antibiotic. It's next gen antibiotic.
Yes, and if we can do that, that would be one major innovation. If AI can help us in creating a better identification of the molecules that have that potential, because the science in actually developing the safety and efficacy of the antibiotic, which goes through the very complex, long clinical trials, takes time. But if
it's like, sorry, I'm just thinking this through. I hate to draw an analogy with sort of weapons, but it's like you develop military drones, and then you give them more and more autonomy. So they become sort of self-driven. They become capable of making their own decisions. So you're almost talking about an autonomous antibiotic.
An antibiotic that we do not develop resistance to, so we can use it for a bit longer, instead of it developing resistance within 2-3 years.
But if it meets a particular form of resistance, this super antibiotic can adapt itself.
That's another stage, actually.
Oh, is
That's
it?
a different. But in doing that, but just one more thought to add to that is, if we can also start developing antibiotics that can be exclusively used in the animal sector. That's another innovation that we want. Why is that the case?
Yeah.
Because 70% of antibiotics that we need for the patients are being used in the human and agriculture.
I don't know how you did it, but you've seamlessly got to the next audience question, which is, and Lord Darcy mentioned it at the very beginning. I dare say, I'm a farmer's son. I dare say there are no farmers in the audience, but we need to talk about agriculture systems. And this questioner does. The question is, antibiotics are used regularly in animal feed at the rate of 2 to 50 grams per ton for improved performance in the animals. Surely this impacts resistance. And what are we going to do about it?
So if you allow me, I'll pick up. Yeah, we need innovative antibiotics, number one, but we go back to public health and hygiene. And how do we walk away from the pressure of producing food and meat and poultry? So the production and the fishery, poultry, and even in the highest income countries, without mentioning countries' names, you can just Google this and see that some industries in the animal and agriculture are using top-notch antibiotics to secure the production for economy's sake.
Yeah.
And that can also be important for the simplest farmer as well. They need to secure that chicken or that goat or the cow or whatever. So there's that balance between feeding people and sustaining economies. So,
but ultimately, whether it be by persuading more and more of the world to forego meat, or just telling farmers that they are prohibited from using this level of antibiotics, something's going to have to be done.
The prohibition, we tried.
We have tried, and sadly, the high-level meeting political declaration did not move us forwards. We would like the farmers to stop using critical, medically important antibiotics, even if they use others. We'd like them to use them only because animals are ill, and fish. So that then takes you into how do you stop them getting ill? And we're back to old-fashioned public health, cleanliness, hygiene, vaccines, but they can work. They work very well. It's just you have to invest in it.
But bottom line, the agriculture/farming lobby was too powerful for you to...
I believe so.
Yeah. Okay. Well, that's one lobby. Then we haven't really talked about the pharmaceutical industry in all of this discussion. So there's a question here. Great questions, by the way. Thank you. I see in this discussion that the pharmaceutical industry point of view is missing, says the questioner. Only mention is that we need more antibiotics to fight AMR. The question is, what are the expectations and the motivations and the drivers within the pharmaceutical industry? So can anybody talk?
So my expectation is they will produce some new antibiotics. The response from many is, well, the amount of money we make from antibiotics, partly because of the behavior of payment, partly because of resistance developing, is not enough to cover the R&D and manufacturing, therefore we won't. We do still have some responsible companies in this world making new antibiotics and looking for them, but it is a real market failure, and we have to work on that, which is why the British have introduced a pull incentive, which means we pay for novel antibiotics or new ones that matter by not only the impact on the individual, but the impact on society as a fire extinguisher that we have there ready to stamp it out. And Italy's announced something similar. The Americans do have a bipartisan act called the Pasteur Act on the Hill, but they don't look as if they're going to pass it, which would do the same. The Japanese have a small pilot. Sweden has an access pull incentive pilot, which you might want to talk to.
Karen, very briefly then, tell us the Swedish perspective.
Yes, really agreeing that we have a market failure, so we need to create the incentives. The public has to take responsibility. One is to really make incentives when it comes to research, but also to give incentives to the private companies to put the antibiotics on the markets, but not having them being used when they're not supposed to be used. So the Swedish initiative, and what has been used now for some years with great success, is that we, for new antibiotics, instead of letting them being put on the market without regulation, we make an agreement with the pharmaceutical companies on that we will have these antibiotics on the market in Sweden, but highly regulated, and we will give a revenue to the companies whether the antibiotic is used or not. So we revenue the companies, make sure that the antibiotics is on the market, but regulated and highly accessible for physicians when it is needed, but only used when it is needed. And if it isn't used, the companies will still have a revenue.
It's interesting. Okay. Thank you, Karen.
Yes.
Very briefly.
Yes,
just-
very
yeah.
briefly. The bad news is indeed that the big pharmas are not interested because this doesn't make profit. And I would very much welcome all these initiatives now to incentivize them. At the same time, let us not forget that there are alternative research and development initiatives that they can also be joining this competition. And we know that as MSF with drugs of neglected diseases in the past, and we have to do this together. And I strongly recommend that we support these kind of initiatives in letting together with the big pharmas to
Absolutely, thank you. Okay, I'm going to leave the last word to Sally, and I'm going to ask Sally to respond to this question, because it seems to me, as we're out of time now, a great way to end what has been a fascinating debate. I mean, it's a question which is both kind of amusing, but also really important, okay? So this is for you, Sally, and this is to invite you to have a closing thought for us. The questioner says, with an estimated, and I love this figure, with an estimated 10,000 trillion bacteria in this particular auditorium, I don't know how we get to that figure, but it's a good one, because the questioner says, you know, they've done a quick calculation of how many people in the room and how much bacteria we all represent. Can we realistically win this battle, or should we aim simply not to conclusively lose this battle?
I like that, because, of course, if we look at it as a war, we are going to lose. If we look at this as to how do we save lives and live with these bacteria, which humanity and all living things have done, we evolved from something very similar, then we should be all right. And I suppose the interesting area that's opening up scientifically is understanding the microbiome, those 10 trillion bugs that are living in us and on us, and how most of the time that keeps us healthy. It can make us unhealthy, and the microbiome can carry antimicrobial resistance that contributes to illness and death. So where we need to be is where rich countries, and I do look to Sweden and the Netherlands in particular, are in balance with what's available and protecting people and the meat industry. And we haven't got there yet, and we've got a fair way to go. But I'm glass half full. I think we can do it.
Good. Well, let's end with that thought. I think, if nothing else, what we've shown here at this Wish is that this is a hugely important challenge, and you guys have helped me present a panel which I believe has addressed it in really interesting ways, but partly because we had some fantastic questions. So thank you all very much for being such a brilliant audience, and let's end by thanking our panel very much indeed. Thank you. Thank you so much. For those of you who haven't had lunch, get out there and have a quick bite to eat, but there's plenty more happening this afternoon, and I hope I'll see you all later. Thank you very much.